You know, our shoulders are incredible. They give us the power to reach for things, to lift our kids, to give a hug. But what happens when all that power is replaced by pain? When you feel weak and it just won't go away? Well, it can be totally debilitating. So today, we're going to dive into a very specific but really common story of shoulder pain.
It's such a frustrating feeling, isn't it? You go to grab something off a high shelf, and your arm just says no. It feels weak, almost like it's not connected right. And this isn't just about getting older. It's a sign that something much bigger is going on deep inside that shoulder joint.
You see, when most of us hear rotator cuff, we think of a simple tear. You know, something a surgeon can just stitch back together. But sometimes a really massive, chronic tear kicks off this whole cascade of events, a degenerative process that leads to arthritis and can literally start to reshape the bones in your shoulder.
And that condition has a name: rotator cuff arthropathy. So let's break down exactly what that means, who it tends to affect, and how it completely rewires the mechanics of your shoulder.
Okay, so that sounds like a mouthful, but the key thing to get is that RCA is basically a three-part problem. First, rotator cuff insufficiency. That just means the cuff is torn so badly it's not doing its job anymore. Second, that failure leads to degenerative changes, which is just a fancy way of saying arthritis. And third, and this is crucial, without the rotator cuff holding the arm bone down, the head of that bone, the humeral head, starts to ride up high in the socket.
So, who usually gets this? Well, the source material paints a pretty clear picture of the classic patient. We're typically talking about someone in their 70s or older. They're dealing with this nagging pain that just gets worse and worse over time, and it really starts to limit what they can do every day. It usually happens in the arm they use the most, and the weakness is a really big deal. And these images here, they show you exactly what's happening. You can see the result of that upward drift we talked about. The top of the arm bone has moved up so high that it's grinding against the acromion, which is the bone at the very top of your shoulder. And over time, this constant rubbing literally reshapes the bones. The ball of the joint becomes rounded. They call that femoralization. And the acromion gets worn into a curve, kind of like a new socket, which is called acetabularrization. So how does a doctor know for sure that this is what's going on? Well, it's really a two-part investigation, combining what they find in a physical exam with what they can see on an X-ray. So during the physical exam, a doctor will feel that very specific weakness and notice a loss of motion, both when you try to move your arm and when they try to move it for you. In the most severe cases, a person literally can't lift their arm at all, a condition they call pseudoparalysis. And then the X-ray is the smoking gun. It confirms everything, showing all those bony changes we just saw. The arm bone has drifted up, the joint space has shrunk, and you can see those clear signs of acetabularization and femoralization.
Now, this is really cool. Doctors don't just say it's bad. They actually have a system to grade the damage, like the Hamada system you see here. It starts by measuring the little bit of space between the arm bone and the shoulder blade. As that space gets smaller, the grade goes up. Once you start seeing those bigger bony changes like acetabularization or even the bone collapsing, you're getting into the highest grades. And this isn't just for record keeping. It's what tells the doctor what treatment to recommend.
Right, so all of this diagnosis and grading leads to a very clear roadmap for treatment. And the best part is there are well-established options, from the simple stuff all the way to a full-on surgical fix.
I like to think of it as a ladder. You always start on that first rung, which is conservative care. That means physical therapy, trying to strengthen the muscles that are still working, like your deltoid, plus things like anti-inflammatory drugs. If that doesn't cut it, for some less severe cases, maybe some minor arthroscopic surgery is an option. But for advanced rotator cuff arthropathy, the gold standard, the top of the ladder, is a procedure called a reverse total shoulder arthropathy. And this surgery is just an amazing piece of engineering. In your shoulder, the ball is on your arm bone and the socket is on your shoulder blade. A reverse does exactly what it sounds like. The surgeon puts an artificial socket on the arm bone and a new ball on the shoulder blade. By flipping the whole setup, it changes the physics of the joint and it allows your big, powerful deltoid muscle to take over the job of lifting your arm. It basically makes the rotator cuff irrelevant. But here's the thing. Getting a new shoulder is only half the story. Just like with any major surgery, the real success depends on what happens next. The real work starts the moment you wake up from anesthesia. And this quote from one of the sources just nails it. Rehabilitation isn't some optional extra you do if you feel like it. It is fundamental. It's every bit as important as getting the diagnosis right and having a skilled surgeon. Whether you're trying to avoid surgery or you're recovering from it, a solid rehab program is the absolute key to a good result.
And that program? Well, it's a marathon, not a sprint. This table gives you an idea of a typical 6-month plan. It starts with 2 weeks where you basically don't move your shoulder at all. Then you slowly, carefully begin passive motion. You don't even start moving it on your own until about week 6. And get this, strengthening doesn't really kick in until 3 months after surgery. It's a long, slow, patient process, but you have to stick with it.
So what happens if a repair doesn't heal right? Well, there's a plan for that too, as you can see in this flowchart. If the pain and weakness come back, another MRI is done to figure out what's up. And from there, a decision is made. Either go back to non-operative treatment to work around the problem, or consider other surgical options. The point is, there's always a logical next step.
So after all of that, the diagnosis, the surgery, the months and months of rehab, what does success actually look like? Well, the outcomes are actually amazing. First of all, the procedure itself has gotten incredibly safe. The overall complication rate for a reverse shoulder replacement has plummeted to just 9.4%. I mean, that's down from a whopping 24% in the earlier days. That's a huge testament to how much the techniques and the implants themselves have improved.
And for patients, the results can be absolutely life-changing. We're talking major improvements across the board: less pain, way better function, and more motion. And here's a fascinating little fact. The data shows that the patients who started off in the worst shape often report being the happiest after surgery, probably because the change in their quality of life is just so dramatic.
So when you boil it all down, after looking at all the science and all the surgical tech, what's the single most important factor that's going to determine if you have a great outcome? The answer is teamwork, plain and simple. Success isn't something the surgeon just gives to you on the operating table. It's something you all achieve together. It's a true partnership between the skill of the surgeon, the guidance of your physical therapist, and, most critically, your own dedication to get through a long and tough rehab. That collaboration, that's where the magic really happens.